Friends, this is a 2 years old female French bulldog, and this dog presented with the history of swelling in the left inguinal region here. So seeing that this is the female animal, so from the distance anybody can misdiagnose as a mammary gland tumor. So when we palpated and we examine, then we find that this is not a hard mass, this is a soft swelling, and it appears that it is cyst-like structure. Then we are told that this swelling he observed basically 1 or 2 days after the mating, and as the gestation period increases, so this swelling also increases in the size. So based on that, we suspected for the hystereocele also, and when we performed the radiography, so we found a small ossified bone of the fetus outside the abdominal cavity, and on the ultrasonography also we find the wall of the uterus in this particular area with the dead fetus. So ultimately we have diagnosed this case as a herniation of the uterus. Probably the pregnancy or implantation seen in this particular herniated area of the uterus, and when the size of fetus increases, probably increases, and the fluid increases. So because of the from the where this is from the inguinal area, this protrusion occurs, so probably that causes the occlusion of the blood supply, and due to that there is a resorption of the, or you can say mummification of the this fetus with the resorption of the fluid also. Also the fluid is still present, but it is not as much as it should be in a normal pregnant animal. So we plan for the removal of this fetus. Since the owner reared this animal for a breeding purpose, so he requested me that kindly try to save the uterus for the further breeding. So for that I will try to save the uterus if the condition is okay. So as far as this plan of surgery is concerned, so I will make an incision here, although the herniation is here, but I will go for the midline linea alba incision here, and then I will reflect this here up to the inguinal canal, and then I will see this structure, and at the same time I also examine the right side as well as the left side of the uterine horn and the both ovaries also, just to see if there is any pathology. So definitely we will remove the uterus rather than preserving the uterus. So this is all about this plan of the surgery. So this one is the umbilicus, so we make the incision from here. So this is the region we should not hurry in the diagnosis of the any case just on the basic clinical sign or seeing from the distance. In other words, we should avoid the snapshot diagnosis. Seizure. So better to increase the incision a bit accordingly. So this is a different case. We have not seen. I have performed the few cases of the hystereocele, but in that case only the uterus, non-pregnant uterus herniated. In this case the herniation with the gravid uterus, although the fetus is not viable. Keep on mopping, very good. So we try to we should remove the fat, whatever the, just to make this linea alba very clear. Now you could see this is the linea alba, white color structure. So before making incision here, let me reflect this one. So this is the region in textbook, and many experienced surgeons, they are telling that whenever you go for the surgery, you must examine the patient thoroughly. have to increase the incision for the caudal. So now you could see, so this is the inguinal blood vessels which are coming from the inguinal canal. So here the dissection should be it should perform carefully. Take the Alice tissue forceps, catch hold this area. Yes, very good. So you could see this is the, now it's much visible, so let me clear with the finger also. So this surgery is right now assisted by the 2 PG students, Dr. Kushwaha and Dr. Tinku, and thanks to Dr. Yawar for recording the case. So here you may differ from my decision that why I am not giving the incision directly over the inguinal. This is the reason, because if I give the incision here, so only such type of decision you can make only when there is a herniation only. Here the herniation is atypical, that is the uterus, and this uterus in the canine, it has the 2 halves. So we have to examine by opening this. Now you could see this is the, so now you could see I am separating the different structure here. So now you could see very beautifully this structure. Now you could see. So this is the reason why I am reflecting, just to show from here this cyc is coming. So if you see, so this is the inguinal canal here. You could see here, this is the inguinal canal, and from here this cyc is herniated. Now you could see here there is a constriction. This could be the probable reason for dying of this fetus. Anesthesia, there is a lightening of anesthesia. Please someone give the maintenance dose. So even we can further, yes, this is very just hold this one, yes, like this, okay. Now you could see this muscles is, you could see here. So next is, then I make the incision here. Now I am going to open the Now you could see this is sometime happened. This one is a separation of this rectus abdominis muscles. Here the artery course and the peritoneum is here basically. So we just make the incision from here and then we cut close. Now this one. So when I scan, so I also find the fluid like structure just like pyometra. So but this the animal basically taking the food and water normally. So animal take the food and water normally, so that's why we can't suspect for the pyometra or some abnormal fluid. So here, so this one now we could see. So this fluid yesterday, now you could see if I pull, so this is the going inside, this is going inside. So this is the fluid, and on ultrasonography this fluid was visible yesterday. So we performed the ultrasonography yesterday. Now this condition is okay, and the other side of the uterus we have to let me slightly increase the incision further. Okay, and then try to see this one is the urinary bladder. No, this is another. This is also uterus. So this one is the left side. Also left side is free here, and probably the pregnancy may not in the, although it is looking like a pregnancy in this one, maybe in the body. Whereas the right side one uterus is very, now you could see this one is the ovary, and this one is very short. So it means I have to give the incision here, and incision. So whenever I give the incision, so I first press this one, lift this one, press this organ so that there won't be any injury. So give the seizure. Emergent bomb seizure. So here I cut. So now this one is the covering. Now you could see this is the uterus. So ultimately I have to remove the dead fetus. So it means I have to make the incision over the uterus. So now you could see this is the uterus. So when I pulling here, so this is going. So here, so this could be this one is this right one here. Okay, so let me remove this dead fetus, which is, now you could see this is the basically body here, if you see. So from here you could see, so this one is the, here it is the body. So it is herniation of the uterine body. Now you could see, can you appreciate, this one is the, let me, it is very okay, this one is actual, this one is the left side. Okay, so this one is the left side, this one is the right side, and this is the uterine body. You could see here the uterine body. So better to make an incision. So here on the dorsum. Okay, this is a very small fetus. So we make an incision here and remove the fetus, and then suture here. I think the uterus is okay, there is no abnormality, so it's better to, then we also remove this fluid. Then we see the further examine the, because of the strangulation you could see there is a bluishness of this structure, so better to, okay. Please someone put the normal saline over this uterus. Give me the drape so that I will try to avoid the leakage of the fluid into the peritoneal cavity. So here I could feel this fetus, very small fetus here, and here the nothing is. The fetus is here in this one, so better to give the incision where the blood supply is there. So I make incision on the greater position. This one is the only. Okay, let me give the incision here. So since fetus is in this particular horn and seeing the blood supply of this one, so I slightly change the decision to make incision from here to here. So just hold, Mishra, hold like this. Okay. So now you could see, so this is a very small fetus. This is the resolved fetus, or you can say this one is the mummified fetus. So this mummification probably occurred. You could see this is the head, and this one is the mummified fetus. And then in the meantime, please someone open the another gloves, so that after doing this procedure I change my gloves. So I will squeeze this one. So this is the another very small short fetus. This is a very small. So this is the region it was not visible in the during the ultrasonography. So I will normally in general, whenever the hystereocele, we prefer to remove the uterus and the ovary, that is the OVH. But here, since the animal is reared for the breeding purpose, so this is the reason why we are trying to save the. So even if some little bit amount of the placenta here is left, so that will come outside through the normal opening. Small force. Give me the drape, or better to although this mummification is a sterile condition, so even if your finger touch here and there, so it hardly matter. So now I change the gloves, and then I first see whether from the squeezing here it is coming or not. No, it is still not coming. So let me increase the incision. So this is the broad ligament here, and this was also visible during the ultrasonography. So we should we enlarge this one canal with the very careful. Say curved. You give the curved artery forceps. Curved artery forceps are rather curved myos. Okay. Anyway, so this one is seizure. So I just and then Misbah hold like this one. Okay. And give the seizure. Mop it. So now I slightly increase the incision. Now let's see whether there may be torsion also. Hold like this. Please someone give the with one hand, just like this, and then give the So this is the advantage of making a midline linear incision. Now you could see. So when I make incision, so the here the inguinal canal only you can say the superficial things only cut, then here the inner one is still intact. So that's why. So now I with the finger inside. Yes. Yes. Now you could see. So we have increased the incision. So there may be chance that now you could see. So better to first remove and then. So now I will release, since here I made the incision, so that is why I am not retrieve all the content from here and then outside. So this is the reason why the surgeon keep on changing the decision while during surgery. So now just by making enlarging of this ring, or rather increasing the inguinal canal, so now this uterus is come outside, and the fluid, whatever the fluid present in this left uterine horn, now come here. So we remove from here. So here one placenta is attached, I think. It is not coming. Either I have to give the separate incision, which is I don't want. Okay. Leave that one. Give the incision. This is strongly adhere. So I tried my best here to remove this one, but I couldn't succeed. So maybe strongly adhere with the endometrium. Mishwa, hold like this one. First I repair this small one which I soft one. Move it. So this exercise I am doing just only to save this breeding capacity of this particular animal, otherwise this procedure would have been finished earlier. So this is a simple Lambert pattern. Now you can focus here only. Keep on mopping. Dr. Tinku, cut it from here. And then we invaginate this particular layer with this pushing pattern. So this incision I can prevent, or you can say skipped, but once it come in my mind, if I open, so we should see. So whatever the placenta particular sac was attached here, that was attached very strongly with the endometrium. So I opened, but I was not able to remove completely, but partially I was able to remove. So this decision could be wrong also, but whatever in my mind comes, so I always believe to see better than without seeing the leaf as such. So now this is how we close the cut it slightly above. Yes, very good. So we repair this one. Okay, now next one is to repair this one. This one hold like this. Okay, just keep like this. Okay, someone increase the rate of the fluid. I think it, if possible, na, write the 100 ml, that one is wet plasma. ठीक है, वेट प्लाज्मा पड़ा है, हाँ ले आओ, हाँ kindly bring the wet plasma because this is the very small breed, so even the mild oozing of the blood may cause the loss of the blood because uterus is here having the lot of blood supply, so better to give the plasma extender. Just hold from one side. Okay, so again this one is the so we first repair in the Lambert pattern. So I repaired the first layer in the Lambert, then the second one is the pushing pattern. So I repaired this hysterotomy incision. So I repair this one and this one. So next, even but after repair you could see slight, you can say, hemorrhage inside the endometrial, so that is basically some clot formation is there. So that's happen if the in gravid uterus oozing of the blood is very difficult. We could see here that this is prominent blood supply, and this is the reason why if I would have cut here, so you can imagine the amount of the bleeding or amount of the this. So now the next I pull the from here. So now you could see this is how I retrieved this herniated content from the hair, this inguinal, from this inguinal canal here. Some of the part is remnant is here, so I will close later on this one. Now it is the uterus, and now it is in the abdominal cavity. So now you could see uterus is healthy. So little bit fluid is still present, so that will definitely once the uterus content, so it will come outside from the normal vaginal canal. So now I put this uterus inside the abdominal cavity and it's routine place. And this one is the left one, from the left towards the left side. So now I inserted this and the next step is to repair this inguinal canal, and then repair of this one, repair of this one, and then repair of this one. So this fat, this is the, so fat I have to insert this like this here, and the rest of the remnant I have to cut, sacrifice here. Keep on mopping here. In the meantime, focus the light here. Yeah, so I have to cut this portion. This is the fat, this is nothing, this is the fat. So I cut close to the ring. So now this is the fat, so it is better to insert the inside the abdominal cavity rather than removing this one fat. This is basically omentum. So now I am going to repair the canal, which I enlarge this one. So better to put the finger inside also. So this one is very close to the here, so I have to take the bite like this. So these are the advantage of making a abdominal or midline lineal vulva incision. And moreover, with the vulva, suppose if I approach vulva from here, so it is very difficult to manage this uterus. Good. So here it is, I could feel that this bone is so. Okay, one more suture, one more bite rather, one or two more bite here. In the male animal it is very difficult because in the male the spermatic cord is coming through this inguinal canal, but this is the female, so only vaginal process coming and okay. So now we have closed this. This is the number 1 polyglycolic acid. Always cut a bit. Okay. Just wait. We have to lift this one and cut this one. Okay. So it's okay. Closed. Okay, fine. Now, Tinku, you just remove your finger. Okay. So next step is the closure of this one, this laparotomy incision, and then closure of this one, superficial. So here we will take the bite in such a way so that the dead space, whatever dead space is formed, that we could obliterate. This closure of the laparotomy incision, as per routine, you have seen so many abdominal surgery in my video, so that I will repair in the same way. But after this one, then definitely I will show how you close this one. Prepare this this abdominal incision. So ideally this rectus abdominis should not be visible. This one should be here, should be here, should be here. Now here it is. So sometimes it happens when the incision is not exactly from the midline. So that is hardly matter. Sometimes it's happen. So this one is also routine, but since here the towards the inguinal canal, so lot of dead space is there. So Give me the forceps, thumb forceps. So taking care of dead space is very, very important in surgery during the repair. So now here I will take the bite in the epineuritic part also, that is fascia. So now you could see how I am taking the bite just to obliterate the dead space, which is very, very important. Now you could see here. So here I am taking a bite only in this rectal sheath, only external rectal sheath, so that they come closer, which I missed during the closure of the laparotomy incision. So now you could see the shape is looking very good. So here again I take the bite like this, and then whatever this dead space like this, again going underneath like this. Otherwise this is the now you could see mop. So beside my surgical team assistant, I am also thankful to the Dr. Ayman for recording this case, and the gynae student, MBSc student, Dr. Yawar and Dr. Rais. So the success of this operation is, the credit goes to all the person involved in this particular surgery, whether they are observing, whether they are doing something. So kindly give the maintenance. So I will make a here the put the cuts. The last step is we just repair this one is in the subcuticular pattern, and finally now from here onward nothing is special. I will go with the subcuticular pattern, and then finally the closure of this skin. So in this way we almost finished this procedure. So thank you very much for watching this video, and if you want to get the notification, if you want to receive the notification frequently from my side, so subscribe the channel and press the bell icon for the further notification. And if you want to see the video which is fully for the members only, so you can become the member by clicking the join button. So this is all about this particular case. So I hope that you will learn a lot of things from this particular case. So thank you very much for watching this video.